session, we will discuss ocular drug delivery system. This is the disclaimer for the viewers. In the last session, we have started with the ocular drug delivery system and we have discussed the introduction, advantages, disadvantages, then anatomy and physiology of eye along with various ocular routes of administration. In the today's session, we are going to discuss the ocular barriers and various strategies to overcome these ocular barriers. So let us see the ocular barriers. Ocular barriers are divided into the anatomical barriers, physiological barriers, blood ocular barrier, and the drug and dosage form related factors. So look at the figure. There are various barriers which shown in the figure, like the sclera and branch barrier, which is present over here. It is due to the branch membrane. Then the blood-retinal barrier, which is present in the retina. Then the tear film, which is present on the cornea. Then the cornea, it is one of the barrier due to the outermost epithelium. Then the blood-aqueous barrier, it is due to the iris and the ciliary body, and the vitreal barrier. So the barriers are divided into the anatomical barriers like a cornea, conjunctiva, and the sclera. Physiological barriers like lacrimal secretion, tear film. Blood ocular barrier like blood aqueous and blood retinal barrier. And the drug and dosage form related factors like a solubility, lipophilicity, and the molecular weight. Furthermore, these ocular barriers are classified as the static barriers, dynamic barriers, metabolic barriers, and the intraocular environment. Static barriers like stratified corneal epithelium, then the corneal stroma, sclera, and conjunctiva. Dynamic barriers like a tear turnover, reflex blinking, nasolacrimal drainage. Intraocular environment, there are two main barriers which are present over there, like a blood aqueous barrier, that is a BAB, and blood retinal barrier, and metabolic barrier like a phase 1 and phase 2 enzymes and the efflux pumps. Furthermore, the static barriers, we have to suppose to consider the cornea, sclera, branch membrane choroid, and the retinal pigment epithelium. In the dynamic barriers, we have to suppose to consider the reflux blinking, then the tear turnover, nasolacrimal drainage, conjunctival clearance, episcleral clearance, choroidal clearance, then clearance by the bulk fluid flow, uveoscleral outflow, hydrostatic and osmotic pressure, along with the RPE transporter proteins, drug efflux pumps, and organic ion transporters. In a metabolic barriers like a cytochrome P450 and lysosomal enzymes. And in intraocular environment like a blood aqueous barrier and blood retinal barrier. Let us see the details of the ocular barrier. Very first one, that is a lacrimal fluid. Lacrimal fluid, it is secreted by the lacrimal glands and it is going to maintain the conjunctiva and the cornea moist and healthy. It is continuously produced by the lacrimal gland and distributed on the eye surface by blinking and drained into the nose. So the majority of tears secreted remains in the lacrimal meniscus until their elimination to inferior nasal metas, and some are distributed on the eye surface and creating the tear film. And tear film, it is going to act as a barrier for permeation of a drug into the ocular tissue. More than 75% of ophthalmic solution is lost via nasolacrimal drainage. So this is the nasolacrimal drainage. Whatever the fluid which is secreted by the lacrimal gland, it is going to be drained into the nasal cavity. So more than 75% of ophthalmic solution lost via the nasolacrimal drainage and absorbed systemically through the conjunctiva, and the ocular viability is very low for the conventional formulation. So the drainage of lacrimal fluid during the blinking towards the nasolacrimal duct induces elimination of the conventional dosage form. So the lacrimal fluid secretion, it is a very first barrier which is going to drain the applied formulation into the nasal cavity, and furthermore, it is going to be promote the absorption of a drug systemically. So this is about the lacrimal fluid. Let us see the tear film. So tear film comprises the lipid layer, middle aqueous layer, and innermost, that is a mucin layer, which is present on the cornea. So tear film is a 3-layered structure composed of external lipid layer, middle aqueous layer, and inner mucin layer that covers the conjunctiva and the cornea. It is the buffered aqueous fluid which is having a pH 7.4 and comprises the electrolytes, lipids, proteins, lysozyme, albumin, and glycoprotein. The instilled drug could bound to the proteins like a lysozyme, albumin, or glycoprotein, or be partially hydrolyzed by the enzymes, and which reduces the further ocular bio. Due to continuous tear production at 0.5 to 2.2 microliter per minute and tear turnover, the contact time of drug with the ocular surface tissue, it is very short, that is 1 to 2 minutes, and as a result, only slight percentage of free drug applied on the corneal epithelium, which successfully penetrates through the cornea into the ocular tissue. So in this way, the tear film, it is going to act as the barrier for movement of drug. Let us see the another barrier, that is a cornea. Cornea, it is the largest static barrier that inhibits the transportation of drug molecule into the eye. As already we have discussed the anatomy and physiology of cornea, which comprises the 5 layers. There is the epithelium, basement membrane, Bowman's layer, stroma, descending membrane, and the endothelium. The main barrier of ocular drug delivery is the corneal epithelium, which selectively controls the ocular drug penetration. And it is composed of single layer of basal cells and 4 to 5 cell layers of a non-keratinized stratified squamous epithelium cells, which are held together by the tight junctions. Whatever superficial cells are there, which are joined by the tight junctions, and that is known as the zonula occludens, to form the effective barrier against fluid loss and pathogen penetration. And furthermore, this barrier, it is going to inhibit the permeation of drug through the cornea. So due to lipophilic character of the epithelium, it contributes as a barrier for 90% of hydrophilic drug and 10% of the lipophilic drug. Epithelial barrier gives easily access or entry to the lipophilic drug than the hydrophilic drug. So the corneal epithelium, it is going to act as the rate limiting barrier for the hydrophilic drugs. In the cornea, the outer superficial epithelial cells, which are joined by the tight junction, right? And the inner endothelial cells displaying macula adherens, which are more permeable, which are joined by the loose, that is desmosomes, which are present over there. Drug uses the transcellular pathway to cross the cornea, where the lipophilicity and the pK are the major parameter that determines the entry of drug molecule into the cornea. The paracellular route predominates for the hydrophilic drugs or small molecular weight, the drugs which are having a molecular weight less than 350 Dalton, whereas the intracellular route predominates for the lipophilic drug. The cornea, here it's a epithelium, this is the stroma, and here it's a endothelium. So here it's a endothelium, this is the stroma, and here it's a epithelium. So epithelium, it is lipophilic, stroma, it is hydrophilic, and endothelium, it is hydrophobic in nature. As cornea consists of epithelium, stroma, epithelium, which is equivalent to fat-water fat structure, the penetration of non-polar compounds through the cornea depends on oil-water partition coefficient of the drug molecules. Transcorneal penetration appears to be hindered by binding of drug to the corneal tissues, as there may be chances of binding of drug to the corneal tissues because of the cornea act as a reservoir and furthermore slowly releasing the drug into the aqueous humor where the level decreases gradually. Generally, the corneal surface, it is a negatively charged and the cationic compounds bind to the cornea and permeate more easily than the anionic species. So after corneal permeation, drugs are distributed from aqueous humor to intraocular tissues, that is iris, ciliary body, lens, vitreous and choroid retina, and eliminated mainly via aqueous humor turnover and the venous blood flow in the anterior uvea. Ocular penetration via scleroconjunctival route, it is more rapid for the hydrophilic drugs than the transcorneal route. So this is about the cornea. Let us see the conjunctival barrier. So conjunctiva, which is present over here. So this is the conjunctiva. It is a thin vascularized tissue that is internally lined to the eyelids and anteriorly to the sclera. So look at the another figure. So this is the sclera. So anteriorly lined to the sclera and inner lining of the eyelids. Conjunctiva, it is composed of two layers, an outer epithelium that acts as a major penetration barrier and its underlying stroma. The outer apical cells, superficial cells of the conjunctiva forms the tight junctions impeding the paracellular drug permeation across the cell layer. So conjunctival scleral stroma with blood and lymph vessels constitutes a barrier to the hydrophobic drugs. Conjunctiva occupies a 17-fold larger surface area than the cornea. The corneal surface area, it is less than that of the conjunctiva, and intercellular spacing in the conjunctival epithelium is wider than that of the corneal epithelium, and hence we are getting the good permeability to the hydrophilic drugs in the conjunctiva. Thus, the permeability of drug across the conjunctiva is greater than the cornea. However, the drug absorption through the conjunctiva, it is still minimal due to presence of conjunctival blood capillaries. So as to drug, it is going to be reached into the systemic circulation and the lymphatics, which can cause significant drug loss into the systemic circulation and thereby lowering the overall ocular viability. The hydrophilic drugs with a low molecular weight, that is a 20 kilodalton, permeate across the conjunctiva, and it is furthermore going to restrict the drugs which are having the high molecular weight. Conjunctiva exhibits the esterase activity, expressing efflux protein as a P glycoprotein on the cell membrane involved in the drug efflux from the cell cytoplasm. Furthermore, it reduces the drug concentration in the conjunctival cells and impairs the drug transport. Let us see the blood-aqueous barrier. So here it's a blood-aqueous barrier which comprises, that is a iris. So this is the iris. Then here it's a ciliary body, right? Ciliary body, iris, which forms the blood-aqueous barrier, as ciliary body comprises the capillaries. This is the aqueous humor. It is protected by the blood-aqueous barrier. So the BAB, it is formed by the iris, then the ciliary muscle vasculature epithelium by the posterior iris and non-pigmented ciliary epithelium. So here look at the figure. So here it's the ciliary process. This is the ciliary body. So here this is the non-pigmented ciliary epithelium. Then these are the ciliary muscle capillaries. Then posterior iris epithelium and the iridoidal capillaries. So this is the iris, right? So this is the anterior chamber, and here the posterior chamber is present. So BAB, it is formed by the iris and the ciliary muscle vasculature endothelium by the posterior iris. So this is the posterior iris and the non-pigmented ciliary epithelium. So look at here another figure. So this is the iris. So here these are the iris endothelium. So here it's a posterior iris endothelium, and these are the yellow colored one. These are the non-pigmented ciliary endothelium. The barrier, it is poorly permeable due to tight intercellular junctions, which limits the passage of substance with high molecular weight or high hydrophilicity. Ions and small solute diffuses through the space between the cells. The active transporters also affects the passive diffusion of a drug depending on their selectivity. Dashed line indicates the leaky vasculature, and the dark solid line which indicates the tight endothelium or epithelium, which makes the blood aqueous barrier. Look at the figure. So here it's a blood aqueous barrier. So iris and ciliary processes. So this is the iris, which is joined by the tight junction, and this is the ciliary body, isn't it? Which makes the blood aqueous barrier. So systemically delivered drug, the tight junction. So these are the tight junctions of the iris vasculature, limit the passage of substance from plasma to the iris stroma. The non-pigmented ciliary epithelium tight junctions restricts the passage of substance from ciliary body stroma to the posterior chamber. So posterior chamber, which is present over here. The BAB, blood aqueous barrier, modulates the passage of molecule between the anterior and the posterior segment, as well as from plasma to the aqueous humor. The drainage of aqueous humor, it is approximately 2 to 3 ml per minute, which also hinders the passage of drug from posterior to anterior. Let us see the sclera. So here, this is the sclera and this is the scleral barrier. So the accessible surface area of sclera, it is approximately 16.3 centimeter square. It is the white of the eye. It mainly consists of an extracellular matrix consisting of collagen fibrils and the glycoproteins. It is more permeable to hydrophilic solutes than the cornea and the conjunctiva. The transcleral diffusion is through an aqueous medium of proteoglycans or the porous spaces within the collagen network, that is a 25 to 300 nanometer, rather than diffusion across cellular membrane. The scleral permeability, it is dependent on the molecular weight as well as the ionic charge. The positively charged molecules have a lower permeability across the sclera than those have the negative charge, as the proteoglycan matrix of the sclera, it is the negatively charged, which contributes to binding of positively charged solutes and hinder their transport across the tissue. So this is the about the scleral barrier. Let us see the branch choroid complex. So here, look at the figure. So this is the choroid, right? So this is the outer collagenous layer. Then these are the cross-linked elastic fibers, right? Then this is the choriocapillaries, and this is the branch membrane, and this is the basal lamellae, right? So here it's a sclera, choroid, and branch membrane. So the choroid is a highly vascularized and inverted tissue supplying the blood to the retina. So this is the retina. Choroid supplies the blood to the retina. So it is composed of network of the fenestration capillaries and supported by the branch membrane, which is about 2 to 4 micrometer pentalamellar elastic membrane that also represents the basal membrane of the RPE, retinal pigment epithelium. So this is a branch membrane, and here it's a retinal pigment epithelium. BC complex possess more critical barrier to the drug delivery by transscleral route than the sclera itself. The molecular size affects the branch choroid complex permeability. So in the branch choroid complex, that is a BC complex, here it's a choroid branch membrane, right? Below the choroid, there is a sclera, and above the choroid, there is a branch, and furthermore, the retinal pigment epithelium, which makes the branch choroid complex, which is going to affect the permeation or the movement of the drug from choroid to the retina. Let us see the retina. Retina is a thin transparent tissue. So here it's a vitreous humor, and this is the retina. Retina comprises the retinal pigment epithelium, RPE, and the neural retina, right? And furthermore, the choroid and sclera is present. So the retina, it is a thin transparent tissue which forms the innermost layer of the eye and which adheres to the choroid. It consists of outer retinal pigment epithelium, that is the RPE, and inner neural retina. So here, look at the another figure. So this is the whole retina. In the photoreceptors, there are cones and rods are present. These are the pigmented epithelium. Here it's a horizontal cell. Then these are the bipolar cells. Then amacrine cells, ganglion cells, and this is the optic nerve. So the RPE, it is the monolayer of a polarized cells, while the neural retina, so this is the neural retina, it is composed of 9 layers within the inner limiting membrane, mainly comprised of extracellular matrix proteins, posing the most significant barrier for the drug permeation. So the retina, it is considered as a significant barrier to ocular drug delivery, with a large molecules penetrating the retina with a progressively more difficulty. Let us see the blood-retinal barrier. So this is the blood-retinal barrier, dark line. So here it's a sclera, choroid, then this is the retina. So these are the retinal capillaries, that is the inner BRB, and this is the cell lining, which is joined by the tight junction, that is the outer BRB. Look at the another figure. So here it's a blood retinal barrier. So this is the inner blood retinal barrier. As you know that this is the choroid, then retinal pigment epithelium, and the neural layer. In the neural layer, which forms the inner blood retinal barrier, right? So these are the Muller cells, and here this is the tight junction. This is the pericyte, and this is the retinal capillary endothelial cells. And outer blood retinal barrier, which is present in the retinal pigment epithelium. So these are the tight junctions between the cells, right? And this is the choroid. So blood retinal barrier mainly hinders the substance diffusion from systemic circulation into the retina. So this is divided into the inner blood retinal barrier and the outer blood retinal barrier. The inner blood retinal barrier is composed of retinal capillary endothelium cells, which possesses the intercellular tight junctions and selectively protects the retina from the foreign substances in the blood circulation, especially hydrophilic compounds and the macromolecules. Whereas the outer BRB is comprised of the RPE, which is located between the photoreceptors and the choroid capillaries. The unique transport processes within the retinal pigment epithelium, along with its critical barrier characteristics, strictly govern the diffusion of the drug. Furthermore, molecular radius is again the major factor affecting the diffusion across the retinal pigment epithelium, with the permeability declining exponentially with an increasing radius. Solute lipophilicity, it is a yet another factor which is going to affect the permeability through the RPE. Only small lipophilic molecule can transfer efficiently between the choroid and the retina, which limits the delivery both inward, that is the blood to vitreous, and outward, that is vitreous to blood direction. Hydrophilic compound permeate mainly through the tight junction. So these are the tight junctions, that is the paracellular route, while lipophilic drug cross the RPE via the transcellular route. So this is the RPE, and hydrophilic drug moves through this tight junction, whereas the lipophilic drug moves by the transscleral route. Let us see the physiochemical properties of drug affecting the ocular tissue permeability. The first one, that is the cornea. Corneal permeability decreases with increasing molecular radius. If the drug is lipophilic in nature, it is going to cross easily the corneal barrier. Preferentially, the drug should have the positive charge. Such drugs are going to move easily into the cornea. Conjunctiva, the permeability, it is going to be decreased with increasing molecular radius. Preferentially, the lipophilic molecules get cross easily the conjunctival barrier. Then the blood-aqueous barrier permeability gets decreased with the increasing molecular weight. Preferentially, lipophilic drug gets easily permeated through the sclera. The permeability decreases with the increasing molecular radius. Preferentially, hydrophilic drug moves easily through the sclera. And the drugs which are having the negatively charged. Branch choroid complex, the permeability, it is going to be decreased with increasing molecular weight, and which are having the negative charge. And blood-retinal barrier permeability gets decreased with increasing molecular radius. Preferentially, the lipophilic molecule permeates well through the blood-retinal barrier. So this is about the how the physiochemical properties of the drug affecting the ocular tissue permeability. So in this part, we have discussed the ocular barrier. Very first one, that is a lacrimal fluid drainage into the nasal cavity. Then the second, that is a tear film. Then third, that is a cornea. Fourth, that is a conjunctiva. Then fifth, that is a blood-aqueous barrier. Then the sclera, branch choroid complex. Then the retina, blood-retinal barrier, and the physiochemical properties of the drug. So herewith we have finished the first part. Let us move towards the second part, that is various strategies to overcome these barriers. Let us see the strategies to overcome ocular barriers. As already we have discussed, there are so many barriers which are present, which affects the permeability of a drug into the ocular tissue. And the major barrier, that is the corneal epithelium, then the blood-aqueous barrier, and the blood-retinal barrier, isn't it? So in the corneal barrier, it involves the epithelial layers attached together by the tight junctions, avoiding the entry of drug particle, followed by the thick stroma and the endothelial cell. Then the blood-retinal barrier, which is due to the choroid retina, that is, these are the red pigment epithelial layer, which makes the outer blood-retinal barrier, whereas here it's a inner retinal capillaries, which makes the inner blood-retinal barrier, right? Then the blood-aqueous barrier, it is made by the non-pigmented cells of the epithelium of the ciliary body and endothelium of the iris blood vessels. Let us see the various strategies to overcome the ocular barriers like corneal barrier, blood-retinal barrier, blood-aqueous barrier, along with the scleral barrier, branch-choroid complex, then the retinal pigment epithelium, and so on. Let us see the strategies to overcome the ocular barrier. There are so many strategies are there which are widely used to overcome the ocular barrier. The strategies are divided into the as a viscosity modifiers, use of viscosity modifiers in the formulation, use of the penetration enhancers, use of the mucoadhesive agent, by using the prodrugs, by using the ocular in situ gels, or by using the nano and the microemulsions. Furthermore, we can use the nanocarrier systems like the nanoparticles, nanomicelles, liposomes, and the dendrimers, and the physical devices like microneedles, ionophoresis, or the sonophoresis. So let us see the various strategies to overcome the ocular barrier, or strategies or various approaches to improve the ocular permeability. Strategies to overcome the ocular barriers are furthermore classified as, or classified according to the target tissue or the target barrier, as to increase the residence time on the ocular surface, like use of viscosity enhancers, use of a mucoadhesive agent, or use of the ocular in situ gels. To target the cornea, it is possible to use the permeation enhancers, then prodrug approach, then by using the nanocarriers, or by using the micro or nano emulsions. For the conjunctival targeting, it is possible to use the chitosan coated nanoparticles or the prodrug approach. For the targeting of a aqueous humor, it is possible to use the nanocarriers like nanoparticles, dendrimers, solid-lipid nanoparticles, liposomes, neosomes, microemulsions, and cationic nano-sized emulsions. For the transscleral penetration, it is possible to use the nanocarriers and the microneedles. Microneedles, it is a physical approach. Then intravitreal retention of the formulation, it can be improved by using the nanocarriers like nanotubes, liposomes, or the nanoparticles. And if we want to target the retinal pigmented epithelial cells, it is possible to use the nanocarriers like nanoparticles, SLNs, liposomes, and the dendrimers, and furthermore, the nanoparticles derived from the gold, silver, zinc oxide, and the magnetic nanoparticles. So these are the various strategies which are widely used to overcome the ocular barriers. So let us see the details. Very first strategy, that is the use of viscosity enhancers in the formulation. Generally, the viscosity enhancers are widely used in the eye drop. So they are going to improve the patient compliance by reducing the dosing frequency. When we are increasing the viscosity of the formulation, the retention of formulation in the ocular cavity, it is going to be increased, and furthermore, which reduces the dosing frequency. As increasing the viscosity of preparation, furthermore increases the bioavailability of drug. As the retention of formulation in the ocular cavity, it is going to be increased or the enhanced. The viscosity range up to 15 to 18 centifoils, it is widely used to prepare the ophthalmic preparation. So because of which have the negligible visual effects. So whatever the formulation which is prepared by using the viscosity enhancers, it should be filterable and it should be sterilized easily. There are natural and synthetic polymers which are widely used as viscosity modifiers or viscosity enhancers, like cellulose derivatives, methyl cellulose, hydroxypropyl methyl cellulose, hydroxyethyl cellulose, then polyvinyl alcohol, polyvinyl pyrrolidine, in the ocular formulation. So addition of these polymers into the formulations requires the additional technological solution, as there may be the chances of the blurred vision due to changes in a corneal refractive index or difficulty in installation of the precise dose. Viscosity imparters generally used in the eye drops or the ocular injections. So when we are increasing the viscosity of the formulation, it improves the ocular retention of the formulation and thereby increases the permeability of a drug through the cornea. Let us see the mucoadhesive polymers. Mucoadhesive polymers, it is a yet another approach which can be widely used to improve the ocular permeation. As when we are using the mucoadhesive polymers, it promotes the adhesion due to interaction of polymeric chain and the mucin layer which is present in the tear film. As mucin and polymer gets interacted, and thereby the formulation, it is going to be retained on the corneal surface. There are so many theories are there which are widely used to understand the principle behind the mucoadhesion, like a mechanical theory, wetting theory, electronic theory, adsorption theory, and the diffusion theory, which is not listed over here. So in the mechanical theory, the diffusion of high molecular weight polymer chain, look at the figure. So this is the formulation which contains the polymer. This is the cornea and the tear film. So there is a diffusion of a high molecular weight polymer chains and the glycoprotein of mucus by interpenetrating into each other by creating an intermolecular net leads to the mucoadhesion. So the due to the interpenetration of the polymeric chains into the mucin chain, there is the mucoadhesion. So in the wetting theory, which describe the effect of drop spreadability and wettability on the eye surface. So wetting phenomenon and the spreadability which is responsible for the mucoadhesion of the specific polymer. According to electronic theory, there is an electron transfer in the mechanism of the mucoadhesion. For example, the polymer like chitosan. Then the adsorption theory, it is about primary and secondary chemical bonds between the polymer and the mucus. There are so many types of the mucoadhesive polymers which are widely used in the ocular preparations, like the carbapoles, then the sodium alginate, methyl cellulose, HPMC, HEC, chitosan, thiolated polymers, and the hyaluronic acid. Hyaluronic acid is preferred because of its biocompatibility, non-toxicity, and the biodegradability. So this is about the mucoadhesive polymer. Let us see the ocular in situ gel. Ocular in situ gel, it is yet another approach or another strategy to improve the ocular permeability or to overcome the ocular barrier. These systems are applied as a solution or suspension and undergoes a rapid sol gel transition, which is triggered by the external stimuli such as the temperature, pH, and or the ionic strength after installation into the ophthalmic cavity. So in situ gels which are present in the form of the solution, and after application it gets converted into the gel form due to the external stimuli. So these formulation combine the advantages of solutions such as accuracy, reproducibility of dosing, ease of administration, then minimum interference with the vision, that is absence of blurred vision, lack of sticking eyelids with a prolonged corneal residence, and resistance to nasolacrimal drainage, reduce the frequency of administration, and the characteristics of the ointment. So these are the some advantages which we are getting when we are using the ocular in situ gelling systems. So ocular in situ gelling systems, these are in the liquid form. After installation, due to external stimuli, it gets converted into the gel form. Furthermore, the gelling systems are going to be classified as a temperature triggered gelling system, then pH triggered, and ion triggered. So in the case of temperature triggered, generally we are using the polymers like poloxam or the xyloglucon. So below phase transition temperature, this system is present in the solution form, and as the temperature is going to be raised, the solution gets converted into the gel form. In the case of pH-triggered in situ gelling system, the pH-responsive polymers like carbapol, which contains the weak acidic or the basic group that release or accept the protons in response to the pH change, and thus conformational changes occur in the polymer structure that determines its swelling and furthermore release of the drug onto the cornea. And the third system, that is a ion-triggered in situ gelling system. So here the cross-linking of sensitive polymers takes place due to the monovalent or a divalent cations in the tear, as tear comprises some cations, say for example calcium. So the sodium alginate or the gel and gum, its cross-linking, it is being promoted by the calcium ions which are present in the tear film. In short, the ocular in situ gels, they are going to promote the residence of a formulation onto the cornea or into the ophthalmic cavity, and thereby improves the permeability of drug. Let us move towards the another strategy to overcome the ocular barriers, that is the penetration enhancers. So penetration enhancers, they are going to improve the permeability of a drug through the specific tissue. So the penetration enhancers, when we are using in the formulation, it reduces the size of instilled drop and improves the bioavailability of the poorly absorbable substances. The most of the substances are the surfactants. Generally, we are using the surfactants as a penetration enhancers that alters the physical properties of cell membrane by removal of phospholipids, or they are going to solubilize the membrane. For example, the benzalkonium chloride, it is widely used as a preservative, but furthermore, it is going to act as a permeation enhancers, and it is going to alter the ocular barrier that can lead to the toxic effects by accumulation in the cornea for several days. Then EDTA is also going to act as the penetration enhancers. It is going to alter the tight junctions between the superficial epithelial cells, and it is going to facilitate the paracellular transport. Then the chitosan, it is having ability to adhere to the surface of the mucosa and temporarily open the tight junctions between the cells, and thereby improves the permeability of drug through the cornea. Then the cyclodextrin, it is going to solubilize the lipophilic compounds by complexation and leads to enhanced drug permeability through the eye with a good viability of active substance. They are going to act as a solubilizer in the formulation for the lipophilic compound, and furthermore, it is going to improve the permeability of a drug through the cornea. As surfactant reduces the interfacial tension and improves the solubility of poorly soluble drug, they are going to alter the membrane properties by disrupting the tear film and the mucin and removing their protective properties, disrupting the integrity of the epithelia by loosening the tight junction or modifying the epithelial cell membrane. For example, it is possible to use the Twin80, Span 60, Transcutol, Labrasol, etc. Generally, the non-ionic surfactants are widely used in the ophthalmic preparation to improve the penetration of drug into the cornea. Let us see the cyclodextrin. So use of cyclodextrin, it is yet another approach to improve the bioavailability in the case of eye drop. So we have to suppose to say, for example, this is the drug. Here it's a CD and it is going to form the complex. So due to the solubilizing capacity of BCD, the formulation or BC complex reached into the tear film, it is going to dissociate, and whatever drug molecules are there which are going to be accumulated onto the corneal surface, and furthermore which promotes the absorption through the corneal membrane. So the most of drug used in the ocular drug delivery, they are lipophilic in nature. In order to cross the tear film barrier, drug should be present in the dissolved state. So cyclodextrin can be used to enhance the solubility of drug in the formulation, The external surface of CD, it is hydrophilic, and internal core, it is a lipophilic in nature. So whatever the internal core is there, it is a lipophilic in nature, and outside it's a hydrophilic in nature, and thereby it can promote the solubility of a drug in the formulation. So cyclodextrin forms the soluble complex with the lipophilic drug by the hydrogen bond, van der Waals forces, and the charge transfer interactions. So in the aqueous solution, there is a dynamic equilibrium is created between the free CD and the drug molecule and the complex. And after application on the eye surface, the only free lipophilic molecule can permeate through the cornea, and the hydrophilic CD remains and it is eliminated through the nasolacrimal pathway. Generally, we are using the hydroxypropyl beta cyclodextrin, gamma cyclodextrin, and sulfobutyl ether beta cyclodextrin. So this is about the cyclodextrins. Let us see the prodrug. Prodrug, it is yet another approach to improve the ocular permeability of the drug. So prodrugs are the pharmacologically inactive compound and derivatives of the molecule that requires chemical or enzymatic transformation for release of active substances. These are the inactive form. They are pharmacologically inactive, and in presence of the certain enzymes, they are going to be activated. So there is an enzymatic transformation of the prodrug into the ophthalmic tissue is used to release the parent drug. The active substances possess the hydroxyl or the carboxyl group, which can be esterified to produce the lipophilic compound. For example, the activity of esterase is 2.5-fold higher in the corneal epithelium compared to the stroma and the endothelium, which is furthermore utilized to deliver the prodrugs into the cornea. Absence of acetylcholinesterase and the butyrylcholinesterase in the tears allows the absorption of prodrug through the corneal epithelium. So the prodrug enhances the permeability of active substance through the cornea with a prolonged precorneal retention. There is one formulation which is available, that is a Cortijet. It is a preservative-free emulsion composed of oily carrier and a phospholipid as a surfactant, encapsulating a target tissue-activated corticosteroid prodrug. It releases the dexamethasone palmitate. This is the prodrug, which is de-esterified by the retina-specific esterase and activated to the dexamethasone. A single intravitreal injection provides sustained release over 6 to 9 months, isn't it? So this is about the prodrug approach to improve the permeability through the cornea as well as to target the posterior segment of the eye. Let us see the microemulsion. So microemulsion, it is yet another approach to improve the solubility of the drug as well as the permeability of the drug through the ocular tissues. So microemulsion is a dispersion of water and oil which is stabilized by using the surfactants and or the co-surfactants, which are going to reduce the interfacial tension. So microemulsions are clear in appearance and which are thermodynamically stable and which is having a droplet size approximately 100 nanometer. So microemulsion formulation increases the solubility of the drug. Generally, O by W type of microemulsions are preferred for the ocular drug delivery. So in the presence of surfactant and co-surfactant, it is able to increase the corneal membrane permeability. So the microemulsions can improve the solubility of drug as well as they're going to improve the corneal permeability of drug. So increase the permeability and sustained release of a drug makes microemulsion as an attractive vehicle for the ophthalmic drug delivery. So microemulsions have low surface tension and high spreading coefficient, which allows for the drug to spread and mix well with the precorneal fluid. And this improves the corneal contact time of the drug. And furthermore, the microemulsions can be sterilized by using the filtration for formulation as a eye drop. So in short, the microemulsions They are going to improve the solubility of drug. They are going to improve the residence of the formulation onto the cornea and the corneal permeability. So this is about the microemulsions. Let us move towards the nanocarriers. So these are the nanocarriers. That is the nanocapsules, nanospheres, nanomicelles, liposomes, and the dendrimers. So nanocarriers, they provide the controlled drug release with a prolonged pharmacological effects. Formulation is retained and localized in the cul-de-sac where the entrapped drug can be delivered by diffusion or under external stimuli such as a light in the case of liposomes. These formulations may have prolonged contact with the ocular surface, withstanding the ocular clearance mechanism. So these formulations have the prolonged contact with the ocular surface as well as they are going to withstand with the ocular clearance mechanism as they are having the size in the nano range. The nanoparticles, so these are the nanoparticles, they are having the diameter less than 1 micrometer and they are made up of the natural or the synthetic polymer in which either the drug is dissolved or it is incorporated or encapsulated. In case of dissolved, we are getting the matrix type of formulation, and in the case of encapsulated, we are getting the nanocapsules. So drug can also be integrated into onto the matrix surface. That is, drug it is adsorbed onto the surface of the nanomatrix. So nanoparticles are well tolerated by the patients and they are going to overcome the ocular barriers. They are going to increase the permeability and maintain the optimal concentration of active substance in a target tissue. Liposomes, so these are the liposomes. These are the small spherical vesicles consisting of the cholesterol and the natural phospholipid. It is possible to load the lipophilic drug in the lipid layer and it is possible to encapsulate the hydrophilic drug into the inner core. Due to their excellent biocompatibility, biodegradability, non-toxicity, and ability to incorporate lipophilic and hydrophilic compound, liposomes are widely used as one of the approach to improve the permeability of a drug into the ocular tissues. So it improves the precorneal retention and slows down the metabolism to the ocular surface. So this is about the nanocarriers. Let us see the physical devices. Very first device, that is a ionotophoresis. So here it's a ionotophoretic device. So this is a technique that enhances the drug delivery across the biological membrane by application of the low intensity electric current. So this is the ionotophoretic instrument which is going to apply the low intensity electric current onto the eye. So here there is a device in which the drug is placed, right? And furthermore, we have to suppose to apply the weak current so as to the drug it is going to be permeated into the cornea, into the sclera, into the choroid, into the retina, to the vitreous. So the ionotophoresis, it offers advantages such as ease of application, then minimal or non-invasiveness, and increased drug penetration directly into the target tissue. The drug is applied with a weak direct current that drives charged molecule across the sclera, choroid, retina, and vitreous. A ground electrode, or you can say it as a return electrode of opposite charge, it is placed elsewhere on the body. So here, look at this I get 2 delivery. So this is the actual device in which the drug is placed, and here the return electrode or ground electrode is present. So the ground electrode of opposite charge is placed elsewhere on the body to complete the circuit, and the drugs serve as a conductor of the current through the tissue. And this is yet another device is that is a ocuphore. So this is about the ionotophoresis. So here we are using the ionotophoretic principle to overcome the ocular barriers. Then the second physical device, that is the microneedles. So microneedle possess the capacity to deliver vast array of drug to ocular tissue located in the posterior portion of eye, for example, sclera. The formulation of microneedle is also customized to create the structure which is only penetrate hundreds of micrometers in the sclera of eye to circumvent possible damage to deeper assemblies of the eye. There are various types of the microneedles are there. That is solid microneedle, coated microneedle, dissolving microneedle, and hollow microneedle. So here yet another figure. So here a self-implanted microdrug reservoir system, okay, then which is inserted and implanted onto the sclera, and furthermore it is going to release the drug into the scleral layer. So with the employment of microneedle, it is possible to specifically place the drug or drug systems into the eye sclera or other intermediate space like a suprachoroidal space. So furthermore, it is possible to place this microneedle device onto the suprachoroidal space in order to improve the ocular tissue permeability. So this is about the microneedles. Then electroporation. Electroporation, it is a yet another physical approach to improve the ocular tissue permeability. So electroporation relies on the relatively high intensity electric field. We are applying the high intensity electric field, typically over 100 volt per centimeter, and a short pulse duration in microseconds or milliseconds. So which creates the pores. So these pores, the hydrophilic drug, it is going to be permeated by the paracellular route, transcellular route. Okay. So these conditions induce the reversible destabilization and transient permeation of cellular barriers, enabling easier access of drug and genetic material to ocular cells and the tissue. Drug can be transported into the target tissue through the pores created by the electroporation. So this is the electroporation device. We are supposed to apply the electric field for the short pulse duration, which create the pore. So through these pores, the either paracellular transport system or transcellular transport system, the drug, it is going to be permeated into the ocular tissue. So this is about the electroporation. Let us see the sonophoresis. So sonophoresis, it is yet another approach. So here we are using the ultrasound waves. So it involves the application of sound field at a frequencies higher than 20 kilohertz to improve the drug transport across the biological membrane along with the ocular barrier. So sonophoresis can be utilized for ocular barrier also, and they are going to improve the permeability of the formulation or drug by the cavitation mechanism. So this is the ultrasound pressure wave. This is the stable cavitation and inertial cavitation. So the mechanism for ultrasound enhanced drug delivery include the non-thermal mechanisms like cavitation, acoustic streaming, and mechanical stress on the membrane, as well as the thermal effects, which improves the permeability of a drug through the ocular tissue. So this is about the sonophoresis. Then yet another device is there, that is the micro electromechanical system. So this is the micro electromechanical system, that is a MEMS. So MEMS comprises, this is the drug reservoir, then this is a perilene cannula, which is going to deliver the drug into the ocular tissues. So here, this is the pump outlet, this is the electrolysis pump. So here we are using the electrolysis mechanism which generate the gas and which exert the pressure on the drug reservoir, and thereby the drug, it is going to be released into the specific cavities. So micro electromechanical system, it can be refilled with the drug solution, giving the long-term drug therapy which avoids the repeated surgeries. It consists of an electrolysis chamber with electrolysis actuation to precisely deliver the desired dosage volume, a drug reservoir with a refill port, battery, and electronics. Biocompatible and flexible Pyrrolene, it is used to construct the MEMS. Battery and wireless inductive power transfer can be used to drive the electrolysis. So electrolysis is a low power process in which the electrochemically induced phase change of water to hydrogen and oxygen gas, which generates the pressure in the reservoir and forcing the drug through this cannula. The reservoir is implanted in the subconjunctival space. So size of this implant, it is very, very small, and the flexible cannula is inserted through the incision into the anterior or the posterior chamber. So directly the formulation or the drug, it is entered into the anterior or the posterior segment. So this is about the MEMS, that is the micro electromechanical systems to overcome the ocular barrier or to improve the drug permeability into the ocular tissues. So herewith we have finished the various strategies to overcome the ocular barriers. We have discussed the strategies like use of viscosity modifiers, penetration enhancers, then the use of mucoadhesive agent in the formulation, then by using the prodrug, then by using the ocular in situ gels, then nano or microemulsions, along with the nanocarriers like liposomes, then the nanoparticles, along with the nanomicelles and dendrimers to encapsulate the drug and furthermore improve the permeability through the ocular tissue. Along with, we have discussed the physical devices like the microneedles, ionophorosis, sonophorosis, and the MEMS. So herewith we have finished the ocular barriers and the various strategies to overcome the ocular barrier or approaches or strategies to improve the ocular permeation of the drug. Thank you very much.